Hi everyone, it's Rona again, PGY2 in Internal Medicine at Walter Reed with another shelf review video. And today we're really going to be focusing on different types of shock. So I wanted to start off with a question. It's a common form of a question you might see on your exams where someone is coming in sick and you're trying to differentiate why are they looking so sick. So you have a 63-year-old male, he's coming in with altered mental status. You notice that he's tachycardic, his creatinine is elevated above baseline, so you see that he has some renal dysfunction, his lactate is elevated, his SVR is high, PCWP and CVP are low. And we're going to go into those variables in a little bit, but SVR is going to stand for systemic vascular resistance, PCWP is standing for your pulmonary capillary wedge pressure, and CVP stands for your central venous pressure. You also notice that his blood pressure is lower, and they're asking you what is the cause. A is hypovolemia, B is heart failure, C is bacteremia, and D is pulmonary embolism. So the answer for this is going to be hypovolemia, and we're going to go into the different reasons why. So the way they're going to show you shock on your exam is someone who's coming in with a lower blood pressure, their lactate might be elevated, and really the hallmark is this poor perfusion. So their kidney function is worse, their liver enzymes are elevated, they might have some altered mental status or confusion. And the first thing I want you to look at is the heart rate high? And this is not going to be a common scenario. Usually it'll be a trauma patient who's coming in with some spinal cord damage. But if they're bradycardic with shock, they're usually trying to think about neurogenic shock where you have some sympathetic nervous system damage, especially if it's a trauma patient. But if the heart rate is high, the next thing I want you to think about is the systemic vascular resistance low? And the key thing I want you to remember is that the name is telling you what this is. How much resistance are you getting from your peripheral vasculature? So you can imagine that if the SVR is low, that means your peripheral vessels are not giving you much resistance. And you can imagine this can happen if your vessels are very dilated. And I really cannot emphasize enough that if you're seeing a patient with low systemic vascular resistance who's not in neurogenic shock, they're trying to get you to think about distributive shock. And so distributive shock, again, you'll see a low SVR. On your exam, you'll usually see a high cardiac output because the sympathetic nervous system is working and trying to compensate. And the three most common reasons are going to be sepsis, anaphylaxis, and adrenal crisis. And now going back to our question, we can actually rule out bacteremia. They were trying to get you to think about septic shock with that option, but you would expect the SVR to be low for a cause of septic shock like distributive. So we're ruling out that option here. And now if the SVR is high, the next thing I want you to think about are what are the cardiac pressures? And when they're showing you cardiac pressures on your exam, this is actually what they're doing, is they're taking this catheter here, they're threading it from a vein into the right atrium, they're going into the right ventricle, and then they're going into the pulmonary artery, and that's how they're getting those pressures that you see on your exam. And essentially, when you see it, what I want you to remember is if you see PCWP, or a pulmonary capillary wedge pressure, they're trying to get you to say that's what the left side of the heart is seeing. If you see CVP, or central venous pressure, they're trying to get you to think that's what the right side of the heart is seeing. So let's apply this a little bit. If you have both a low CVP and a low wedge pressure, that means both the left and the right side of the heart are seeing low pressures. So what can you think of that would cause that? The answer for this one is going to be hypovolemic shock, so the heart is able to push things forward. There's just not enough to pump. What would you expect for a pulmonary embolism? So if you have something like a massive pulmonary embolism where a clot is blocking blood from flowing into the left side of the heart, you'd expect the left side of the heart to have low pressures, so that pulmonary capillary wedge pressure is going to be low. Meanwhile, the blood is going to be backing up into the right side, so that CVP, or the central venous pressure, is going to be high. And this really visualizes why you're going to have a high CVP and a low pulmonary capillary wedge pressure. You can see there's this clot here that's preventing blood from flowing and filling that left side of the heart. So that left atrium pressure, which again is going to be your PCWP, is going to be low, while the right atrial pressure, which is going to be your CVP, is going to be high. And now what would you expect for someone who just had a bad MI and is now coming in with cardiogenic shock because their heart itself is struggling? And this would be both high pressures on the left and the right side of the heart because blood is able to flow in, but the heart is not able to push it forward. And now what would you expect for someone with cardiac tamponade? Now this is a little bit trickier. You're essentially having blood surround the whole heart, so you're having trouble with blood moving into the heart, so both pressures on the left and the right side of the heart could be elevated. And now this is how I want you to think about obstructive versus cardiogenic. If the CVP and the wedge are different, so if the pressure on the right side is high, but the pressure on the left side is low, they're trying to get you to think about obstructive like a massive PE. Now, if the CVP and the wedge are both elevated, so the pressures on both the left and the right side of the heart are high, this could either be obstructive or cardiogenic. So they're going to want you to look at the clinical picture. And so some obstructive causes, as a reminder, it could be things like cardiac tamponade or a tension pneumothorax. And just thinking about tension pneumothorax, what's happening is that you're having air enter and unable to leave. So it's going to be compressing the heart here, and it's obstructive because it's preventing that blood from moving into the heart. And then you can think about tamponade again. You have blood surrounding the entire pericardium, so you're having difficulty with the heart filling with blood because of that compression. And so let's go back to our question here. We saw that the SVR was high, so it can't be distributive, so it's not going to be bacteremia. Both the wedge and the CVP are low, so for heart failure, you would expect that left side of the heart to have elevated pressures, so that's not going to be our answer. And for pulmonary embolism, you would also expect that CVP or the right side to be high. So the answer for this one is hypovolemia. And now just to summarize again, if you're seeing a low SVR, they're trying to get you to think about distributive shock. If you see a low CVP and a wedge, they're trying to get you to think about hypovolemic. If both the CVP and the wedge are high, they can either be cardiogenic or obstructive, so they're going to want you to think about the clinical picture. And now let's think about the individual types a little more carefully. So a tension pneumothorax, what is going to be the difference between a pneumothorax and a hemothorax on your physical exam? So in pneumothorax, you're going to have hyperresonance on percussion, and you're also going to have absent breath sounds, while for a hemothorax, you'll have decreased breath sounds and dullness on percussion. And what type of shock is tension pneumothorax going to be? This is going to be our obstructive shock. And just as an example of how you might see it is a 20-year-old male coming in after some type of trauma to the chest, coming in with low blood pressure, high heart rate. You're noticing some distended neck veins, and you notice that breath sounds are absent on the right side, and he's in severe respiratory distress. And what would you expect to see on imaging for a tension pneumothorax? So this is going to be, again, that deviation of the trachea, and you're not going to see any lung markings. And this is just an example of what you might see on your exam for someone with a tension pneumothorax. You can see here the trachea is deviated, and you see here you have this lung marking going out to here, and then you have absent lung markings all the way out here. That's showing a tension pneumothorax with deviation of the trachea. And now let's move on to cardiac tamponade. So what could you see with the blood pressure? And I'm trying to get you to think about a specific buzzword that they might use on your exam. So this is going to be our pulsus paradoxus, so the systolic blood pressure dropping by more than 10 millimeters of mercury with inspiration. And what if you see this triad of hypotension, distended neck veins, and muffled heart sounds? Do you know what the name of that triad is? So that's going to be Beck's triad. And then what type of shock is cardiac tamponade going to be? Again, remembering this is obstructive shock. And then there's another buzzword that you might see with cardiac tamponade where they say that the jugular venous distension is getting worse with inspiration. Do you remember what that buzzword is? So that's going to be your Kussmaul sign. And what are some potential causes of cardiac tamponade? And there are a couple, so they can be a complication of aortic dissection. If you have someone with pericarditis, that increases your risk of developing a pericardial effusion, which could eventually lead to tamponade. If you have a patient with malignancy, they can have a very slow growing effusion. So they might have a very large effusion before they develop cardiac tamponade. A post-MI complication, something like a free wall rupture, and other procedures as well, like a CABG, can lead to a hemorrhagic tamponade. And then going back to distributive shock again, remembering what is the SVR? It's going to be low. And what are the three common causes? It's going to be sepsis, anaphylaxis, and adrenal crisis. And what is the first line treatment for septic shock? So I put fluids and antibiotics in bold because really what you want to start with is the fluids. If their blood pressure is still low, then the next line is going to be norepinephrine. And what is the first line treatment for anaphylaxis? This is going to be epinephrine. And what is the first line treatment for adrenal crisis? This is going to be your IV steroids. And adrenal crisis, just zooming in a little bit, if you have someone who's coming in with hyperpigmentation, is that reflecting primary or secondary adrenal insufficiency? So this is primary, and the reason is that the hyperpigmentation reflects the ACTH being high, because a high ACTH is going to increase your melanocyte stimulating hormone, which causes that hyperpigmentation. So if you see someone coming in with hyperpigmentation, they're trying to point to the primary causes. What if someone has a history of a Neisseria infection and they're coming in with adrenal insufficiency? That's trying to get you to think about that Waterhouse-Friderichsen syndrome where you have hemorrhagic adrenal insufficiency. And what is the synthetic form of ACTH used to diagnose adrenal insufficiency? That's going to be your concentropin. And just remember, if you give concentropin in primary adrenal insufficiency, there's going to be no change because the ACTH is already high. So giving additional synthetic ACTH won't help increase the levels of your serum cortisol. And that'll be different in patients with secondary or tertiary adrenal insufficiency. And going into anaphylaxis, which is another type of distributive shock, you might not necessarily see wheezing. So this is how they could trick you on your exam. It can be a patient who's just coming in with nausea and abdominal tenderness or GI involvement. They're tachycardic and have this generalized itching sensation and hypotension. And they're trying to get you to know that that patient is in anaphylaxis. And what if you have someone who's coming in with anaphylaxis seconds to minutes after receiving a blood transfusion? There's something you should consider testing for. It's going to be your IgA deficiency. And so just going into the shock pathway again, if you see someone with a low heart rate or a history of trauma, think about neurogenic. If you see a low SVR, think about distributive. So the three most common causes are going to be sepsis, anaphylaxis, and adrenal crisis. If you see someone who has a high SVR, but the CVP and the wedge are both low, remembering those are the pressures on the left and the right side of the heart, think about hypovolemic. So the heart is able to push things forward, there's just not enough to push. If the CVP is high, so the pressure on the right side is high, but the pressure on the left side is low, think about obstructive like a massive PE, which is preventing blood from moving to the right, from the right to the left side of the heart. And then if the CVP and the wedge are both high, use your clinical clues to differentiate some of those obstructive causes from cardiogenic. And essentially, when you think about shock, there are two main scenarios. One is problems with the heart pumping, and that can either be issues with the heart itself, so the heart is weak, it's cardiogenic shock. You have issues with blood getting into the heart, something obstructive like tamponade, tension, pneumothorax, or massive PE. There's not enough blood for the heart to pump, so hypovolemic, whether you're bleeding or you're hypovolemic from dehydration. If you have collapse of the sympathetic nervous system from something like neurogenic shock. And then the second scenario is going to be if the SVR is too low, so you have some kind of distributive shock, whether that's septic shock, anaphylaxis, or adrenal crisis.